Good morning, everyone. Today we are going to discuss BPE in our preparation urology oral exam series. In the last few sessions in BPE, we have discussed the voiding symptoms and the management. Today we will concentrate on the storage symptoms, and obviously treating the storage symptoms and voiding symptoms go hand in hand in BPE. BPE on prostate cancer are the two tables where the examiner will ask for or expect a lot of references and evidences. Let's crack on. Anish, floor is yours.
Thank you so much, and good morning, everyone. So we will start straight away. You are in the BPH table. The scenario is a 68-year-old gentleman referred by GP for bothersome lower urinary tract symptoms. It is a routine referral. So how are you going to evaluate and manage him?
So I'll see this patient in my dedicated LUTS clinic. I'll request that the patient has attends with an IPSS card and has a flow rate and bladder scan, post-void scan on arrival. When I see him, I'll take a history, examine him, and I'll bring some tests. In my history, I'll establish how long he's had the symptoms, ask about specific low tract symptoms, frequency, urgency, nocturia, poor flow intermittency. I'll ask about red flag symptoms such as recurrent UTIs or hematuria. I'll ask about risk to the upper tract, if he's had any nocturnal enuresis. I'll also ask about his bowel function. I'll then document his past medical history and examine the patient. With a chaperone, I will be performing a focused urological examination, examine his abdomen for any palpable bladder, his flanks for any tenderness. I'll examine his genitalia, foreskin for any phimosis. And then I'll perform a DRE to assess the prostate for the size, consistency, and any associated tenderness. Given that he is 65, I would arrange some tests, including using these as well as a PSA after appropriate counseling.
Well done. Any other special investigations do you want to do in the outpatients?
A flow rate and a post-void scan.
Okay, well done. So do you have a pen with you?
Yes.
So I'll give you some values. So in the history, he's diabetic and hypertensive, well controlled with medications. General examination, BMI 35. DRE reveals a moderately enlarged prostate, but otherwise normal. Examination was slightly difficult. IPSS score shows storage predominant symptoms with an Nocturia of 4 times per night. Quality of life score is 5. The flow rate and bladder scan shows voided volume 160 with a Qmax of 12, Q average of 6, and post-void residual of 25. Okay. So how do you want to manage him from here?
Okay, so with the values that I've got, it's got predominantly storage, low urinary tract symptoms, which are bothersome. So I will inquire more about his fluid intake, especially if he takes caffeinated drinks or fizzy drinks, and I will advise him to discontinue those if he does. I would also advise this patient. So my management would involve conservative management first, which would involve lifestyle modifications like cutting out fizzy drinks and caffeinated drinks. And I would also consider starting this patient on an anticholinergic to help with his predominantly storage low tract symptoms. I note that his Qmax is also 12, which is not great. So I would also consider starting him on tamsulosin for his objectively poor flow.
Okay. What's the value of frequency volume chart here?
So a frequency volume chart is useful to have an objective assessment of how much his intake, his output, but also to try and distinguish between predominant daytime symptoms or nocturnal polyurea. So I'll definitely ask him to complete a frequency volume chart as well.
Okay, and in your practice, how do you arrange for frequency volume chart?
So I will give this to the patients and ask them to complete a 3 days worth of entries, not necessarily back-to-back days, and I will ask them to record what they're drinking and how much, and each time they go to the toilets to pass it into a jug and document the volumes that they voided as well as the time, and bring this back to clinic.
So they will bring it back when they come for the review, isn't it?
Yes,
okay.
Or they can post it ahead of their review.
Okay, that's brilliant. And you said that you will give a combination of tamsulosin and an anticholinergic, isn't it?
Anticholinergic, yes.
What's the evidence for that?
I don't have any evidence on top of my head.
Okay.
Sorry.
So this is one of the commonest questions that can be asked, whether we can combine tamsulosin and solifenacin, especially with the availability of the combination medication. So that's where the Neptune 1 and Neptune 2 study comes.
Okay. Neptune, yeah, thanks.
Where the Neptune 1 study, so in fact the whole Neptune study is the combination of tamsulosin and solifenacin.
Yeah.
The first part was the Neptune study, which was a 12-week double-blinded randomized control study, and then the Neptune 2 study is an extension of the original study, which was a 40-week extension. So now we have evidence of almost 52 weeks. That's almost 1 year follow-up for persons on tamsulosin and solifenacin as a combination drug. And they concluded that the combination of tamsulosin and solifenacin is well tolerated and efficacious.
Okay.
Incidence of AUR with the combination is only 1%, and the need for catheterization is around 0.7%.
Thank you.
Is there what's the role of mirabegron in storage predominant lower urinary tract symptoms?
So mirabegron is a beta-3 agonist, which is effective in improving storage lower urinary tract symptoms. It acts by stimulating the beta-3 receptors to encourage relaxation of the bladder during storage phase.
Are there any contraindications to start mirabegron?
So contraindications would be uncontrolled high blood pressure, mainly. So this would be the main contraindication to starting mirabegron.
Okay, and at what dose will you start mirabegron?
So I will start at 50 milligrams once a day. I'm aware that there is a lower dose of 25 milligrams.
Okay.
But in my practice, if the patients, if the symptoms are significantly controlled with 50 milligrams, then the patient can reduce to 25 milligrams.
Okay, brilliant.
Or if they've got significant side effects, then they can drop down to the lower dose.
Okay. So your patient, you started him on tamsulosin and solifenacin. He came back with a frequency volume chart after 3 months, which was, he's saying that his symptoms has improved. His initial frequency volume chart before he started medication showed a frequency of about half to 1 hour, and there are no wet episodes, and average fluid intake is 1800 mils with an output of 1200 mils. His symptoms has improved at 3 months time, and he so what will be your further follow-up plan at 3 months?
So at 3 months, having looked at his IPSS, I will repeat his flow rate and post-void scan to check that there isn't a significant post-void residual. I will also look at his quality of life score, which would be my main indicator. And if the patient is happy, then I'll be happy to follow the patient up again, or simply discharge them if they're happy.
Okay, so you reviewed the patient again after 6 months time. At this point of time, his storage symptoms are recurring, and he's saying that he's going back to what it was previously. Would you consider surgery at this point of time?
So given that I'd only tried sulfenacin, I could try a different anticholinergic, or I could try merobegram to see if this improves his symptoms before jumping into surgery.
Okay, well done. And what if the medical management is not improving the symptoms further?
So if the medical management is not improving his symptoms further, given that this gentleman has predominantly storage LUTs, however, on his flow rate scan, there was also some evidence of outflow obstruction with his low Qmax. I will organize for this gentleman to have urodynamics to aid my counseling for bladder outflow obstruction surgery.
Okay, and what will you specifically look in the urodynamics for this gentleman?
So I'll be looking for evidence of diffuse overactivity. I'll also be looking for evidence of bladder outflow obstruction.
Okay, and his urodynamics showed end filling diffuse overactivity at a maximum systometric capacity of 180 mils. What will be your counseling for him?
So I will warn this patient that he has significant diffuse overactivity, and bladder outflow. This is likely secondary to bladder outflow obstruction. Can I just check? Did he also have bladder outflow obstruction on the urodynamics?
Yes, definitely. It showed high pressure flow as well.
Okay, so I'll explain to him that he has diffuse overactivity, likely secondary to bladder outflow obstruction. The key point in my counseling will be that following bladder outflow obstruction surgery, his DOC, his overactive bladder symptoms will likely worsen, and he may feel worse first before things get better. And it's important that he understands that he may even have urge-associated incontinence due to significant diffuse overactivity following relieving of his bladder outflow obstruction. And if patient is in agreement, then I'll go ahead and perform his surgery.
Okay. What percentage of patients' storage symptoms improves after bladder outlet obstruction surgery?
So that will be about 60%.
Okay. And what's the evidence for that?
Not on top of my head, I'm sorry.
Yeah. So it is from Abraham's paper early in 1979. Which showed that there is at least 50% of the persons will improve their storage urinary symptoms when the bladder outlet obstruction is performed. It was repeated. I mean, there's a repeat paper by D'Annunzio in 2003 as well. But Abraham's paper is the landmark paper on that aspect.
Okay, thanks.
And moving forward, his initial IPSS showed that there was nocturia, or 4 times per night. How do you define nocturia in ICS terms?
So nocturia is defined as symptoms of waking up to void in main sleep. Okay,
well done. And what is nocturnal polyurea?
So nocturnal polyurea is defined as where a patient voids predominantly the urine outputs at night. Objectively, when you look at the frequency volume chart, it will be more than the nocturnal output will be more than 1/3 of the 24-hour output.
Okay. Yeah, so that was the previous ICS definition, because we always thought that we have to look only at the nighttime sleep, nighttime sleep period. Then recently the ICS updated, saying that it's very simple now, saying that it is excessive production of urine during an individual's main sleep period. This was changed to encompass those people working night shifts. So that,
Okay.
so that's why it's a bit straightforward and simple now. But for practical purposes, again, we have to focus on the main sleep period. And if there is more urine production during the main sleep period, then that it can be considered as nocturnal polyurea. But the main thing is the total 24-hour urine production will remain the same.
Okay.
What is nocturnal polyurea index?
I don't know.
Or
I'm sorry.
in other words, at what level would you consider the patient has nocturnal polyurea? Is it different in young adults and older patients?
Okay, so for younger patients, I think if it's more than 20%
exactly
over 24-hour outputs. I might be guessing. I'm sorry. For older patients, more than 1/3.
Exactly. Yeah. So you're right there. So
okay.
The nocturnal polyurea is defined as more than 20% of the urine output at night in young adults and more than 33% in patients older than 65. Nocturnal polyurea index is just expressing it in an index value like 0.2 for young adults and 0.33 for older patients. What are some of the reasons for nocturnal polyurea, especially in old age patients?
So the main reason will be imbalance in the secretion of antidiuretic hormone, which is peaked at night. And you could also have other causes like diabetes, or if they're on antidiuretics and they've taken this at night. So these are the main causes of nocturnal polyurea.
Okay, well done. I will just add a couple of more things on that one, especially the obstructive sleep apnea.
Yes, absolutely,
yeah. And then
and heart failure as well.
Heart failure and renal failure as well.
Yeah.
And we can divide the causes of nocturia. Mainly, it could be due to the bladder storage problems and sleep disorders, and it could be as part of global polyurea, or it could be pure nocturnal polyurea. So we have to differentiate all these four types so that we can manage the person well. Because if it is due to a problem with the sleep hygiene, then sending to a sleep lab and using a CPAP might be the treatment that's what's needed.
Yes.
Okay. What is ADH?
ADH is antidiuretic hormone, which is elaborated by the posterior pituitary gland, and it functions to in the distal tubules to facilitate reabsorption or insertion of aquaporins and reabsorption of water.
Well done. The keyword there was aquaporin. Well done. So how do you manage a person with possible clinical diagnosis of nocturnal polyurea?
So the management will depend on the cause of the nocturnal polyurea. If this is due to sleep apnea, then referring to the sleep clinic and commencing a CPAP machine may be beneficial. If the patient if this is due to antidiuretic hormone problems, then a prescription of Desmopressin may help to solve this problem. If it's due to heart failure, then optimization of heart failure could be essential, or changing the time of their diuretic therapy to late evening may also help. So management is mainly based on the causative factor.
Okay, well done. So we can start with the conservative strategies first, and then if the patient is on diuretic, then we can change the diuretic time to mid or late afternoon and see if that works. And one of the other practically possible things that we can request is to try to cessate the fluid intake at least 4 hours before the bedtime. And sometimes using, especially in persons with congestive heart failure or persons with peripheral edema, on general examination, then we can offer the option of using lower extremity compression stocking, so that there won't be much pooling of fluid in the lower extremities during the daytime, which might help with the nocturnal polyurea. You said about desmopressin. What is desmopressin?
So it's a synthetic analog of antidiuretic hormone, and it works on the same principles in the distal tubules to facilitate reabsorption of water.
Okay.
The key thing to note with desmopressin in adults is the potential cause of hyponatremia, and this needs to be monitored when an adult is commenced on it.
Okay. And how do you monitor serum sodium?
So that would be by sending samples for urea electrolytes, and also urine osmolality.
Okay. And how do you monitor it? Like how often do you repeat the serum sodium to when you commence the patient on desmopressin, especially if the patient is around more than 65 years old?
I think initially every 4 weeks.
Okay. Yeah, so the recommendation is to start, we had to have a baseline, and then at 4 weeks, yes, that's right. And so before that, so baseline 1 week and 1 month. So that is the recommendation.
Okay.
And if it is remaining stable, then we can do it later according to the clinical need.
Yeah.
Okay. Well done. So we will stop here now, because it's very unlikely that you will get a storage predominant lower urinary tract symptoms in the BPH scenario. It's mainly, it will be voiding symptoms, and also the surgical and medical management. But in one of the mock vivas I got for almost 10 minutes, it was predominantly storage only.
Okay.
Only storage. And the whole scenario went like this one, and I was not prepared at that time, so I went back and read about the storage symptoms.
Okay.
More, because I was expecting only voiding symptoms and more like a surgical medical management. So sometimes if this is asked, it is better to get prepared for that one as well. That's why I thought that we will discuss this one as well.
Okay, thank you.
Any questions regarding the discussion today?
No, that was very good. I just need to update revise the papers, and
Neptune is one of the studies that we have to remember, especially in storage predominant BPH. The other trials, synergy for the the anticholinergics are mainly in the OAB scenario. But Neptune was by Drake et al. Bristol team.
Yeah. Okay. Thank you. I'll
just chip in and add few things. Is it okay?
Yeah, brilliant. Thank you.
Yes, please.
Yeah. The number one, when you are discussing the side effects for mirabegron and dose adjustments, make sure the dose needs to be adjusted also for liver and renal diseases.
Okay.
And any patient with predominant storage symptoms, as per the NICE guidelines, you guys need to do a flexible cystoscopy to rule out possible urothelial lesions like TCC or CIS.
Okay.
Okay, consider these two things. Yeah, go ahead.
Thank you.
Thank you. So we will discuss the next scenario on Friday. So I'll start.